Thanks, Dr. Goldenberg. Well, crowd's a little bit thin. I hope there's no casualties from holiday shopping. But to take a look at the location of GU trauma, the majority is actually in the kidney. We've talked about lower tract GU trauma previously, and today is going to be the second part completing the series. So I'm going to start with renal trauma, take a look at imaging indications, then take a look at absolute and relative indications for management, and then take a look at some of the complications. For ureteral trauma, I'll break it up into penetrating, blunt, and iatrogenic injuries. And these are the sources that I'll be using predominantly. So let's start with renal trauma. The incidence is 1 to 3%. It's of young males generally, and associated injuries are common. Blunt mechanism of injury is the most common. It happens in the majority, and in Canada, by a series by Dr. McLaughlin and Baverstock, it's 93% VGH. Motor vehicle collisions and falls are the main mechanisms of injury there. Penetrating trauma comprises a smaller proportion depending on which center you're from. And you're more likely to have severe renal injuries from a penetrating trauma than a blunt. The likelihood of a renal injury is greater with a gunshot wound. And just to know that high velocity, greater than 350 meters per second for a gunshot has greater blast effect, it has greater tissue injury than a lower velocity gunshot. Everyone knows the AAST classification for renal trauma. I just wanted to highlight that at some centers, they grade multiple grade 3 or 4 lacerations as a completely shattered kidney. However, the term completely shattered kidney should be just reserved for parts of the kidney that are devitalized and that are completely dispersed and unable to repair. This is a diagrammatic representation of the grading. And so the AAST is validated. Increasing grades has been associated with serious negative outcomes. It's actually the most predictive variable for predicting the need for kidney repair or removal. There's some additional components to the AST that have been suggested, that a segmental infarction without a laceration arising from a thrombosis or a laceration of a segmental artery be classified as a grade 4, as well classifying EPJ avulsion as a grade 5 injury. These haven't been in the validation studies, however. So on history and physical, you want to assess for hemodynamic stability, take a brief history in terms of the circumstances around the incident, get a brief focused history on any previous renal abnormalities or renal surgeries, and then take a look for a physical exam on chest, abdomen, pharynx, or back, and try to assess if there's any clues that there may be a GU injury. Renal abnormalities are a risk factor. Patients with renal abnormalities have increased vulnerability in blunt renal trauma. And you should consider their presence if the injury is out of proportion to the degree of trauma. There's a 6% incidence of renal abnormalities in GU trauma and a higher percentage in children, the most common being hydronephrosis, followed by cysts, tumors, and then abnormal renal position. Urinalysis is the most important lab study. A urine dipstick is reliable. Serial hemoglobins as well as serum creatinine are useful. However, a word of caution is that hematuria may actually be absent, especially in severe injuries such as pedicle injuries or EPJ avulsions. As well, it's notorious for being absent in certain penetrating injuries as well. However, for blunt trauma, the distinction between gross and microscopic hematuria is important because it can have predictive value for the likelihood of a major renal injury. And so everyone basically knows the imaging indications for renal trauma. I'm just going to go through them briefly here. Penetrating trauma has half of them being a severe major renal injury. You should have a high index of suspicion if the wounds are to the chest, flanks, or abdomen. Taking a look at adult blunt trauma, the degree of hematuria as well as the systolic blood pressure are factors to look at in determining whether to image or not. Patients with gross hematuria or with microscopic hematuria and shock have an incidence of 12% of a major renal injury. However, when you take a look at microhematuria and systolic blood pressure greater than 90, there's a very low likelihood of missing a severe renal injury. Taking a look at the pediatric population and blunt trauma, the blood pressure is not a reliable criterion for imaging, as this is a rather late change when patients get hypovolemic. So taking a look at the threshold to image being at 50 red blood cells per high power field, you really miss only 2% of major injuries if you use that threshold in a combination of studies. However, there's no prospective studies really taking a look at this. Yeah, that's the recommendation right now, is that you can safely preclude imaging if there's microscopic hematuria less than 50, or if there's no mechanism. Obviously, if in a pediatric patient, if there's a rapid deceleration injury, I think you would have to keep a high index of suspicion for that.
Are you going to say no?
I would say this, 50 red blood cells is fairly consensus, yeah. So CT abdomen and pelvis is the gold standard for imaging.
Well, I still think you have to be awfully careful with this. I think walk away is not image the patient at all. I have a tough time with that. I don't know quite how to obtain 40% of that patient parents about that. So I just worry. I mean, it's not perfect. It's discriminatory, but it's not perfect. I just worry about making that major investigation or more investigation specific based on this criteria. I'm comfortable with it.
Okay. And so a CT scan is basically the gold standard and is used in almost all trauma centers. It's useful because it assesses other intra-abdominal injuries. Arterial venous phase is important because it assesses for any arterial extravasation. As well, a delayed scan is routine at 10 or 20 minutes. However, there's been some expert opinion that it may be omitted if the kidneys are normal and there's no perinephric, retroperitoneal, or pelvic fluid. It's controversial there. So what to look for on the CT scan? Three major findings that you want to take a look at to rule out a big renal injury is medial hematoma, medial extravasation, and a lack of parenchymal contrast. Now, some patients are unstable and require immediate laparotomy and can't undergo a CT scan. And so the diagnostic test of choice is an intraoperative IVP. It's performed with a 2 cc per kilogram IV contrast bolus. You take a abdominal X-ray at 10 minutes. Basically, it's done to confirm contralateral function and rule out any big life-threatening injuries.
What you're saying is in the adult, unless your blood pressure or your gross hematuria, you don't investigate. In the child, unless you're greater than 50 red blood cells, do not investigate.
If you're less than 50, then don't investigate in the child. Mechanism of injury, that's always the fallback if you have a high index of suspicion.
Because I think when we look back 5 years from now in hindsight, I think we've over-imaged too many people now.
Mm-hmm.
It's become an explosion in the payment systems when we start looking and curtailing us unless we curtail ourselves in this imaging.
Mm-hmm. Mm-hmm.
Marty, do you use these criteria? One issue you're operating was the age of how are you going to screen for that?
Yeah, well, I mean, I don't know if I use it because I'm still up. I do a lot.
Yeah.
So the other concern is some of the medical legal aspect of the background. You say you miss 11%.
Is 0.2 to 2%, depending on what you're looking at. 2%. Yeah.
So even at 2%, there's going to be some issues with that.
True. I think the majority of those were grade 3 lesions, but yeah, that's good.
Either can in the trauma blood pressure is good. We have WBCs, RBCs here. We do investigate it. We do study on.
Well, it really depends on its context and how concerned you are and circumstances around the event. Yeah. True. So in intraoperative IVP, can help avoid renal expiration safely in 32% of patients. Other imaging modalities include a regular standard IVP. However, it has fairly low sensitivity and it's not the standard of care. As well, an ultrasound has inferior resolution, but it may be useful in post-op fluid collection follow-up as well as conservative management. Renal arteriography should be used if you suspect a renal artery thrombosis or segmental arterial injuries, as well as a test of choice for renal venous injuries. Retrograde polygram is of limited use in the acute setting. However, you can consider it if the CT cannot rule out a collecting system injury, as well as an MRI is of limited use in the acute setting. Follow-up imaging, the indications include unexplained fever, flank pain, a mass, or bleeding. It's recommended that a repeat CT scan performed at 36 to 48 hours for grade 4 to 5 trauma to reassess extravasation as well as the hemorrhage. There's no standardized protocol to assess for resolution of grade 4 extravasation, and there's expert opinion that you may only need to image if the patient's condition has deteriorated. However, this is not a consensus statement. Taking a look at the European guidelines for surgical management, they're quite similar to other guidelines, but in general, they advocate that blunt trauma for grades 1 to 4 can be conservatively managed, and for penetrating trauma, grades 1 to 3 can be conservatively managed. Taking a look at the absolute operative indications from the renal consensus guidelines, they're quite straightforward. If you have persistent life-threatening hemorrhage, if you have a renal pedicle avulsion, or if you have expanding pulsatile and contained retroperitoneal hematoma, basically it's a vascular grade 5 injury. Just remember to assess the contralateral kidney if you're thinking of doing a nephrectomy there. But when we're talking about relative indications, it's a little less straightforward. And so there's quite a list there, and we'll go through them one by one here. So taking a look at urinary extravasation, the majority tend to resolve spontaneously. However, in gunshot wounds, there should be a lower threshold to explore because of the blast effect. The spontaneous, that's without stenting. However, large renal pelvis lacerations are unlikely to resolve with ureteric stenting alone, and so that's why it's been advocated that repair be performed. Taking a look at coexisting bowel or pancreatic injuries, this happens less than 2% of renal traumas, and it's thought that there's an increased incidence of major complications, especially if there is extensive renal injury, urinary extrav, or devitalized renal segments. However, this increase in incidence of major complications hasn't really been seen in more modern series, and that makes for some controversial management. Some of the centers are advocating conservative management for these injuries, whereas others are a bit more aggressive. However, the technique, if you are to operate, would include trying to get some tissue or mental interposition, as well as leaving a drain. The subject of devitalized parenchymal segments greater than 20% associated with the urine leak has been shown to have a higher incidence of major complications, including bleeding, urinoma, and abscess formation. However, again, there's a greater trend towards conservative management with stents plus or minus percutaneous drainage if there's a persistent leak, or angioembolization if there's a delayed bleed. With devitalized segments, there's no increased incidence of renal vascular hypertension following this.
Mike, what's the background, please? What are your numbers in touch bleeding, urinoma, and abscess
with this category? Okay, there's no one, I think, out of town. Okay. For persistent bleeding, it'll be in the ballpark of 5 to 20%. Urinoma is 1 to 7%, and abscess is 1%. So it's not in the majority of patients. Obviously, they need to be followed in any conservative management protocol. The thought is these complications can be managed with more less invasive techniques such as stenting or percutaneous drainage, as opposed to a major operation. And then talking about renal vascular injuries, your options are nephrectomy, reconstruction, or radiological interventions. So more specifically, taking a look at renovascular injuries, the majority are for penetrating traumas. And it should be noted that for avulsed or lacerated vessels, they often require exploration because of exsanguination or continued bleeding. When you take a look at the nephrectomy rate, it's a greater rate if there's injury to the main renal artery versus the main renal vein. For segmental artery injuries alone, there's often no management for that. For venous injuries, a reminder that avulsion requires either a nephrectomy or repair, depending on whether it's a solitary kidney or not. Again, for arterial injuries, avulsion requires nephrectomy. However, there's an increasing trend towards observation for these injuries. For segmental arterial injuries, again, no intervention is required. For thrombus or intimal injury, they can be safely observed. There's been several limited case series examining the role of stenting in intimal arterial injury. However, they've been small and the evidence hasn't quite been clear. For solitary kidney injuries, that pushes you more towards acting. That goes to our next relative indication, is complete renal artery thrombosis of both kidneys, or if you've got a solitary kidney. And those are basically our indications for renal artery reconstruction. However, revascularization is seldom indicated if there is a normal contralateral kidney. And that's because the success of reconstruction is quite poor, and the risk of hypertension isn't significantly changed with revascularization. The factors for success include duration, and most would recommend attempting only if the patient's presented less than 5 hours from their trauma. As well, the degree of ischemia and presence of collateral flow are factors involved in success. So taking a look at unilateral renal artery injury, the presence of a normal contralateral kidney, more and more it's often observed. And really the only indication is if you're undergoing a laparotomy anyways, the patient is stable, and you've diagnosed the injury early and you can salvage that kidney. But renal vascular hypertension isn't necessarily improved with the revascularization, and routine nephrectomy may be too aggressive in this instance.
We explored quite a few of these in the past, and it's interesting. In one successful case, greater than 10 hours, Don Skinner.
Oh.
Don Skinner, when he was a resident at Mass General, wrote it up. We explored quite a few of these in the past because it was sort of in group. And we did have one success, now I don't know what it was. But if you look out in the literature, Don Skinner is now the cancer guy. He was the one that was used as the benchmark.
Okay. So when you do have take them to the OR, you want to do a midline trauma laparotomy. You want to reflect the transverse colon upwards and then reflect the bowel to the right, and then identify the IMV, and then just go medial to this right on the aorta. And so this is what's describing as early vascular control. Carroll and Makinich wrote a paper in 1982 taking a look at vascular control and showed that it decreased nephrectomy rates. However, subsequent series haven't really supported this. However, the majority of people would try to get early vascular control if there's a completely shrouded kidney or if you're planning to take the kidney out. Following early vascular control, then you can enter the retroperitoneum into Gerota's fascia, and your options there are nephrectomy, partial nephrectomy, or repair of the kidney itself. Taking a look at operative and nephrectomy rates in blunt trauma, take a look at the most studied series. Yeah, that's a young man. You can take a look at the most studied series at UCSF and compare it to our own rates at VGH. At UCSF, they're quite aggressive. They take grade 3 and 4 injuries to the OR, whereas the VGH numbers reflect what most centers would do. It's interesting to note that basically, along with most centers, when you take them to the operating room, the kidney usually ends up in the bucket. So for renal reconstruction, the principles are similar to partial nephrectomy. You want to have complete exposure, debridement, you suture the bleeders, close the collecting system, you close the parenchymal defects. The use of fibrin sealants have been used and it's been shown to be quite effective, as well as omental interposition, and you can leave a drain. The follow-up for these post-op patients, the European guidelines suggest repeat imaging while in hospital, nuclear renogram prior to discharge, as well as a follow-up at 3 months, including a physical exam, urine analysis, and radiological investigations. However, there's an increasing trend towards conservative management for renal trauma. The adage is, if you don't operate on the kidney, then you can't do a nephrectomy. Some institutions have instituted an ultra-conservative management policy where they don't take even severe renal injuries to the operating room. And this has shown a decrease in nephrectomy rates in 19 to 30% safely without an increase in complication rate. Delayed intervention is required in 0 to 2% overall of these traumas and a higher percentage of higher grade traumas. So taking a look at blunt high grade 4 traumas, the majority can be managed conservatively with a fairly low nephrectomy and complication rate. There have been even some trials taking a look at or some studies taking a look at conservatively managing grade 5 parenchymal lesions. And it's been suggested that grades 1 to 5 parenchymal can be given a trial of conservative management. However, grade 5 vascular is a different story. They often have major exsanguination and should be taken to the operating room. No, the majority of the traumas will be in the younger population, but I don't think that was one of the factors that were predictive of outcome. Taking a look at stab wounds, there's smaller percentage of patients that can be managed expectantly. However, they can too have a low nephrectomy rate. You have to just be cognizant that there is an incidence of delayed bleeding in this population of 20%, and they have to be followed closely if they're conservatively followed. As well, gunshot wounds can be conservatively followed. The numbers are small, and the percentage that can be conservatively managed is small as well. However, they too can have a low nephrectomy rate if followed in this manner. But really, there should be a lower threshold to explore these patients because they often have significant blast effect. Follow-up imaging is only really required in grades 4 to 5 trauma with a repeat CT scan and delays and a renogram at 3 months. However, if there's any other indications such as the fever, flank pain, continued bleeding, these patients should be imaged as well. Complications include urinoma, an abscess, secondary bleed, hypertension, renal insufficiency. So the majority of extravasation will resolve spontaneously on its own. However, the incidence of urinoma or abscess is in the ballpark of 1 to 7%. Risk factors include devitalized fragments, coexisting pancreatic or enteric injuries, if there's a source of infection, and if there's penetrating trauma. The renal consensus guidelines suggest percutaneous drainage of the urinoma or abscess with or without ureteric stenting, whereas some authors advocate using just a ureteric stent or perc nephrostomy tube with or without perc drainage. Delayed bleeds are often secondary to AV fistulas or pseudoaneurysms. They can happen 2 to 36 days following the injury, and they happen in quite a significant proportion of conservatively managed grades 3 and 4 injuries. They often do need intervention. They won't resolve spontaneously on their own. The incidence of hypertension following trauma varies according to study, but the general incidence is 5%. In renal artery occlusion, there's an increased incidence, and there may be transient hypertension in a small proportion of patients. The pathophysiology is from renal ischemia, whether it be from renal artery occlusion, from devitalized fragments, or from a page kidney, leading to excess renin production. The time course is widely variable, And the use of a routine nephrectomy to prevent renal vascular hypertension has conflicting evidence to suggest this use. The recommendation is for grade 4 and 5 to have periodic blood pressure for a couple of years, but however, there's no guidelines or intervention or no guidelines or indications for imaging of these patients. It is one of the relative indications to operate. However, there are reports of spontaneous resolution of hypertension. As well, medical management can be effective in a proportion of these patients. Often, the surgical management of choice will be the total nephrectomy. Capsulotomy for a chronic page kidney has low success, as does renal revascularization. The incidence of renal insufficiency is 0 to 7% overall. The renal function is worse in patients that have a nephrectomy versus those that have a repair or those that are conservatively followed. In those that are conservatively followed, higher grade 5 injuries may have a lower renal function than those that are lower grade. And just to note that acute renal failure in these trauma patients can be multifactorial. It can be from hypovolemia, contrast-induced nephropathy, etc. So let's moving on to ureteral trauma. External ureteral trauma is quite rare. It's almost always associated with intra-abdominal injuries, and gunshot wounds are the most common mechanism, followed by stab wounds. Blunt ureteral injury is quite rare. However, you always have to have a high index of suspicion, especially in pediatrics with a rapid deceleration mechanism. Iatrogenic injury is the most common. The location really depends on the etiology. For external trauma, it can be anywhere depending on where the trauma is. For blunt injuries, it tends to be in the UPJ or proximal ureter. And iatrogenically, it's distal ureter. There's a AAST, a grading classification that's not often remembered or used. The diagnosis can be tricky at times because hematuria is an unreliable sign. The absence does not necessarily rule out injury, and it's present in only half of ureteral traumas. For blunt traumas, patients with a hyperextension or deceleration mechanism should be suspected, especially in kids or patients that have great fall from a height. Delayed diagnosis is most common, and you really have to think of it when patients have a prolonged ileus, a urine leak, fever, sepsis, persistent flank pain, if they have urinary obstruction or elevated creatinine. The key thing is really to have a high index of suspicion and have a low threshold for imaging. Delayed diagnosis has been shown to have an increased complication rate. Surgical exploration is a reliable and accurate means of diagnosing with or without indigo carmine or methylene blue. All the periureteral gunshot wounds should be explored, as well as associated retroperitoneal hematomas, laparotomy. So taking a look at penetrating ureteral injury, stab wounds to the back and abdomen should be suspected. They tend to have short segment ureteral loss. This is in compared to a gunshot wound where there's a significant blast effect. From the blast effect of the gunshot, the tissue may initially appear to be normal. However, there can be up to a 2 centimeter microvascular damage beyond the level of gross injury. Diagnosis in the penetrating ureteral trauma includes one-shot IVP. However, this isn't really reliable with a low sensitivity. The ureteral consensus guidelines states that the complete IVP is accurate. However, the overall accuracy is quite low and it has a wide range. Retrograde pyelograms is the most sensitive and specific. However, it's of limited use in the acute setting. And the use of CT scans has insufficient data because the majority of these patients are taken to the operating room. Untreated, these injuries can lead to stricture, necrosis, or fistula. Patients with minimal contusion can be managed with a ureteric stent. However, with severe contusions, they should be segmentally excised and ureteric repair performed. Again, high velocity gunshot wounds will have an increased rate of delayed leaks. And remember to adequately debride ureter to viable ureter when you're doing a repair. The timing, early treatment is preferred for its management. If the patient is unstable, you can delay the definitive reconstruction. For a delayed diagnosis or for a secondary leak following repair, you can place a percutaneous nephrostomy tube and then later change this to an antegrade ureteric stent. Retrograde stenting is often unsuccessful. Associated bowel injury or fecal contamination has no increased complication rate in this population, and urinomas can be managed with percutaneous drainage. Moving on to blunt ureteric injuries, which are quite rare, delayed diagnosis is most often the case, and CT scans with delays are the gold standard. It's more sensitive than IVP. Typically, it's to the UPJ or the proximal ureter. For partial UPJ obstruction, UPJ injuries, you can primarily repair or manage it with a ureteric stent. Complete UPJs require repair. So going on with iatrogenic ureteric injury, it's the leading cause of ureteric injuries, and the majority are from our gynecology colleagues. They often happen in the distal ureter. For hysterectomies, it happens in 0.5 to 2% of all hysterectomies, and a greater incidence in radical hysterectomies. It often occurs when they ligate the ovarian or uterine vessels. As well, for a vaginal approach to a hysterectomy during the vaginal vault reconstruction, that's when they can nab the ureters. As well, colorectal vascular surgery and an US can cause these injuries as well. Main risk factors: intraoperative hemorrhage. It decreases visualization, and really should try to avoid blind cautery or suturing in this circumstance. As well, large pelvic masses, previous pelvic surgery, infection, and radiation are other risk factors. However, most reported injuries have none of these risk factors, and to prevent these injuries, you really want to try to have adequate exposure and identify the ureter along its course. There is no clear benefit of preoperative ureteric imaging, and ureteric stenting does not necessarily ensure prevention of the injury. However, it does help to identify the injury when it does occur. To diagnose these injuries intraoperatively, again, a key thing is exposure. You can use methylene blue or indigo carmine injected into the ureter using 2 or 3 cc's with a 27 gauge needle. As well, ureteric catheterization, either cystoscopically or through a cystotomy, can be helpful. Signs of ureteric devascularization include wall discoloration, absence of capillary refill, and a lack of a bleeding edge. However, most are not recognized intraoperatively, and therefore you have to rely on radiological studies. An IVP or CT IVP can show extravasation, delayed function, dilatation, or ureteric deviation from the sutures. However, retrograde polygram is probably most accurate and it's useful, especially in a delayed diagnostic setting. You can also do a poor man's IVP by taking a KUB X-ray 30 minutes post a CT scan with IV contrast. You can do this if you have a high suspicion or if the CT is non-diagnostic. So what to do when you have the bat signal and you're asked to manage these iatrogenic ureteric injuries? For vascular graft surgery, it's controversial. There's no clear consensus. Your options include nephrectomy, and this is the treatment of choice in the past. However, if the urine is sterile, there's no increased failure rate or graft infection rate if you perform a ureteric repair. For suture ligation, you have to really assess the ureteric viability. If it's in question, you should try to repair it. If minimal, you can remove the stitch and leave a ureteric stent in place. For the vaginal approach, some authors have recommended routine IV indigo carmine followed by cystoscopy to assess for ureteric integrity. If the surgeon is performing a cystocele repair, intraocele repair, or bladder neck suspension, then that suture could be removed if there's no indigo carmine coming out. However, if it's a vaginal vault reconstruction or vaginal hysterectomy, typically you need to reimplant the ureter, and the sutures aren't typically removed because it's usually a number of sutures that are placed. For delayed diagnosis postoperatively, if it's an absorbable suture, you can place a percutaneous nephrostomy tube until the suture reabsorbs. C-section injuries are low. It's often an emergent setting, and in order to expeditely remove the baby, a lateral extension of the uterine myotomy is performed to the broad ligament. When the subsequent hemostatic sutures are placed, they can injure the ureter at that point. The bleeding as well as the gravid uterus can make visualization of the ureter difficult. As well, IV methylene blue can be inaccurate because of the hydroureter and the decreased peristalsis of pregnancy. Actually, relatively few of the urology consults actually end up having a ureteric injury, and that's why most authors would suggest that open dissection of the ureter to identify any ureteric injury may have more risk than benefit. The preferred diagnostic method is to place a ureteric catheter either cystoscopically or through a cystotomy and assess for whether it goes up quite easily or not. If it does go up easily, then you can leave a ureteral catheter for several days and image with a retrograde pyelogram in the post-op setting if you're still concerned. Obviously, if you have fluoro capabilities, then that would be the management of choice in the C-section suite. For crush injuries, the likelihood of a significant injury is high. However, ischemic injury manifests itself in several days. The factors involved include the clamp size, duration, and amount of tissue in the crush injury. For minor injuries, a stent is a minimum. If in doubt, segmentally resect and repair. For devascularization injuries, this is often delayed diagnosis with a leak or a stricture. Intraoperatively, the ureter may be extensively skeletonized or there may be cautery. Viability is difficult to assess in most cases, and the ureteric stent should be left at a minimum. Again, if in doubt, segmentally excise and repair. For partial transections of the ureter less than 50% of the diameter, you can enclose this primarily with a stent as well. For complete or greater partial transections, should divide the ureter and repair it. Ureteroscopic injury is decreasing in incidence over the years because of improved equipment and smaller flexible ureteroscopes, as well as surgeon experience. Perforations are low, but they can be managed with ureteric stent, and avulsion injuries can be managed as per transection injuries, depending on the level of injury. Laparoscopic ureteric injuries often present again with a delayed diagnosis. It's most common after endometriosis laser ablation or MIS-assisted vaginal hysterectomies. Management is again as per open cases, and if diagnosed intraoperatively, there should be a low threshold to convert to an open, depending on the surgeon's comfort level in repairing it laparoscopically. With fecal contamination or bowel injury, again, this does not decrease the success or does not increase the complication rate of ureteric repair. You should try to have tissue interposition in the repair, though. Management options for ureteric injury. For the timing, you really want to repair it at the time of the injury if possible. However, if there's a delayed diagnosis greater than 5 days, which happens in most iatrogenic or blunt injuries, then you can manage it with a percutaneous nephrostomy tube and subsequently change this to an antegrade stent. Open repair may be required if there's a persistent leak or if there's a stricture. Retrograde stenting is often unsuccessful and should be attempted for low-grade injuries only. Definitive repair should be delayed or staged, especially again if the diagnosis is greater than 5 days. However, in the time interval between the OR and 5 days is a bit of a gray zone. In the patient that's unstable, coagulopathic, or acidotic, delayed ureteric repair should be performed when the patient is stable. The options at that time are ureteric ligation with a percutaneous nephrostomy tube or a ureterostomy. Primary closure should be performed if it's low-grade partial laceration. It should not be used for gunshot wounds because of the blast effect. A UU is the option of choice for upper or middle ureteric injury. Again, you should try to debride to viable ureter, spatulate on opposite sides, perform a watertight tension-free anastomosis over a ureteric stent and drain it. You can also place a omental wrap around it as well. For the distal ureter, the ureteric reimplant is the treatment of choice, and decision to proceed with a SOSH or a Bayer flap really depends on the amount of the length of segment involved. For extensive ureteric loss, the options include a TUU, ileal interposition, a renal autotransplant, or a nephrectomy. Often these are not performed in the acute setting. You can manage these patients with a percutaneous nephrostomy tube, ligate the ureter, then have a discussion with the patients about your elective options, as these are major undertakings. There are complications from ureteric injury. They're often secondary to ischemia or necrosis. Fistulas can occur especially in patients with infection, radiation, foreign bodies, or cancers. They can be managed with a ureteric stent or with a repair. As well, ureteric strictures can occur as well. So in summary, for trauma, you always have to think about ABCs, take a focused history, and then stage the patient. For renal trauma, the AAST stage is important. It's especially with the CT scanning being in routine use. Intraoperative IVP is important in this case of a laparotomy setting, and it's really used to assess the contralateral kidney. There's a trend towards more conservative management even for higher grade injuries. For ureteric injuries, you have to maintain a high index of suspicion. Immediate diagnosis and management is preferred. If really you're in doubt, you can repair the ureter. For distal ureteric injuries, try to reimplant, and the management of choice for mid or proximal ureteric injuries is the UU. So that's the end of my talk. Just want to say happy holidays to everyone.